Good morning, everyone. Today I will present you something about skin manifestations in CDG. But before doing so, would like first to thank you for the invitation to speak here today. So we are going to take a walk through the different skin manifestations in CDG. And before doing so, we want to first know something about what is skin all about and what are the primary functions of skin. Now, when we take a closer look at our skin, we see that it actually consists of three different layers. We have an upper layer, also called the epidermis, which has mainly a protective function. Next, we have the dermis, the second layer, which contains a lot of elastic fibers that not will only protect the structures that are lying within the dermis, but that will also confer elasticity to the skin. In a third layer, called the hypodermis, we mainly find fat cells that will keep us warm in winter. When we are then taking excuse me, a slight mist there. Apart from the three layers, we also have several appendages like hair, nails, and sweat glands that also contribute to the different functions of the skin. When we are then going to take a look at a closer look at the different functions of the skin, we see that it's actually a very important organ in our human body. And that it mainly has a function of protecting us against the world that is surrounding us. One main feature of protection is sensation. The skin can interact with the world around us, can feel what is happening in the world around us, and it does this by these receptors that are present underlying the first layer, underlying the epidermis. So that we can differentiate between touch, between pressure, between pain, between warm, between cold. And this is very important because when we are reaching for a cup of tea and it's way too hot to touch, our skin will tell us that's indeed way too hot and way too hot to touch, and we will pull our hand back when we are touching it so that we won't get any severe burns. Another form of protection is that skin protects us from water in our environment to just enter our body. This means that we can safely take a shower or go for a swim without swelling up of all the water that is surrounding us and that is entering our body. The other way around, skin will also be a barrier for fluid loss. And this is also important if we take into account that over 60% of our body weight consists of water. We don't want to lose that all just when we are standing here or sitting in the seats over there and it's 34 degrees outside. How does skin do that, making this water-resistant barrier? Skin is actually just like a brick wall. And in the upper layer, the epidermis, we see that there are cells, the keratinocytes, that represents the brick of the wall. And these keratinocytes, they produce a cement, a lipid cement, that it's called keratin. And the keratin forms thus the lipid glue between the different bricks. You all know when you're playing with lipids and water together, they never will mix. And in this way, the skin will keep out the water. This also means that when you put lipid ointments, creams, on top of your skin, because skin likes lipids, that it can enter skin. So we can give children or grown-ups medication through skin when it has a lipid composition. On the other hand, we can also excrete stuff from our skin, but we do this on a very regulated manner. And so we mainly make use of our sweat glands to do so, and in this way we can also excrete in small amounts some waste products of the skin, like, for example, ammonia. But when you had too much alcohol, for example, to drink, also our sweat will contain some traces of alcohol. So, yeah, we could do an alcohol test on skin if it would be necessary. Another form of protection is that skin forms not only a mechanical barrier against the outside world, but that it also protects us from pathogens, and these are bacteria, viruses, etc. And also this function is mainly taken care of by the epidermis, the layer of keratinocytes. And you see, it's only a very thin layer. It's 0.1 millimeter thick, but it's a tough layer, and that's the most important thing. In the epidermis, we see that the young keratinocytes are always proliferating at the bottom, and then will migrate through the surface. So a keratinocyte that became sick will go further until it's shed off. The second function within the skin that will protect us against these viruses and bacteria is the fact that the skin has its own immune system. And the immune system in the skin is represented by a cell called the Langerhans cell here. And this cell will take everything that is that the body is not used to, like viruses, pathogens, but also chemicals that you are putting on top of your skin, will eat it and put it in little pieces, and then calls the general immune system and says, okay, this is our intruder, I want that you get rid of it. A second, we are already at, I think, the fourth reason why skin protects us, is that skin forms also a barrier against UV radiation through sunlight. And this is mainly done by the melanocyte, which is laying at the bottom of the epidermis. And the melanocyte is going to produce pigment called melanin, and will distribute melanin to the different keratinocytes. And it won't just enter the keratinocyte, it will be localized just over the nucleus like a little umbrella. You see it here, here, here. And in this way, the melanin will protect, like umbrellas, our genetic material from damage by UV radiation. The problem actually is that our body needs to get a balance between protecting against UV radiation and synthesizing vitamin D, because indeed we also need UV light to synthesize vitamin D within our skin. And that's then also the reason why, when we are going to look at the several parts of the world, people have a different skin color. Because in Africa, for example, there is a lot of sun during the whole day long. So they need a darker skin to protect them from this UV light, but not too dark, so that there is still vitamin D synthesis possible. When you go to the north, to, for example, Belgium, where I come from, you see that the skin is lighter. You see it also at my face. I'm pretty light. And there you see the skin is lighter because there is almost no sun in Belgium. It rains always there. So I don't need a lot of pigment to protect myself from the sun, but I will. And the other reason is, excuse me for the stumbling, is that otherwise I wouldn't be able to synthesize vitamin D with these few hours of sun exposure. On the other hand, in the summer, most people can tan, so get a darker skin color, so that we can protect ourselves better from UV radiation. The last level of protection that skin is governing us is about heat regulation. When it's like now, 34 degrees outside, we will need to be able to sweat. Otherwise, our body would heat up. And if our body is heating up above a certain temperature, organ damage will occur. Like, for example, the muscles will break down. It's called, with a fancy word, rhabdomyolysis. When the brain gets too hot, there will be seizures, and one can go on for a few hours like that. Now, how is the skin regulating heat and temperature? When it's hot, we want to get rid of all the heat that is inside of our body. And so all the blood vessels are going to dilate so that the blood is going to the surface of the skin. Now we need a mechanism to get that this heat is evaporated. Therefore, the hairs are going to lay down because otherwise they are in their way. And the sweat glands will produce a layer of fluid that is on the surface of the skin so that the heat can be evaporated. On the other way around, when it's cold outside, we want to keep all the heat inside of our body. So all the vessels will constrict. They are much thinner than on the slide before. We don't want to lose by any way any heat, so we get goosebumps. Our pores of our hairs will constrict, and the hairs become to stand straight up. And since all the hairs are standing straight up, they will catch the air that is surrounding us, and so that this air that is captured between the hairs will form an extra coat to keep us warm. Next, we will walk through a few topics, a few skin manifestations that we can encounter in CDG. And of course, we will start off by the ones that are most frequently reported in our patients. First of all, we have the abnormal fat distribution. And you cannot see it good on this picture, so I put the figure of an orange next to it. It's the orange peel skin that we often see at this at the sites of abnormal fat distribution at these fat pads. And it means that the skin is a little bit more bumpy than it should normally be, and it really looks like an orange juice that has been for several days in your fruitment at home. Another fancy word for orange peel skin is cellulite, and I think that a lot of the women here in the room are familiar with that. The third fairly common manifestation in CDG are the inverted nipples. It's not specific for CDG, but because there are also a lot of syndromes that present with inverted nipples, and even in the healthy population, we see that a lot of males and females, literature says about 10% of females have inverted nipples without having any disease. Next topic, ichthyosis. Again, a fancy word, and the fancy word means that your child has a fish-scaled skin. So we have little scales on top of the skin. And this fish-scaled skin occurs because there is a problem in the barrier. And since the barrier is feeling okay, there is something wrong going here, it will produce more and more and more cells in an attempt to restore the function of the barrier. It tries, but it doesn't succeed. The cells that are produced don't attach very well, and they will get loose at the top. And that is what you can see here nicely on the boy and here on the abdomen. Third topic, cutis laxa, fancy word for wrinkly skin. This is a problem not of the upper layer of our skin, but of the middle layer, the dermis of the skin, where we have our elastic fibers, and it's really a problem of the elastic fibers themselves. Normally, when we pull our skin, you can try it by yourself, it will bounce nicely back. And only when you get around 100 years, you will see, that is not working anymore because our elastic fibers are getting old and we get a really wrinkly face. In patients with cutis laxa, this is already going on from birth. So they pull their skin and you see what is happening. It's stretching very far away from the surface, and it won't bounce back nicely. So it can go from wrinkly skin, what we sometimes see at the neck or at the abdomen of the patients, but some patients also really have skin folds, like here on this picture. And when you're looking to the face of these patients, they often have this really droopy face, like they're sad for a non-good understood reason, but actually they can be happy children. It's just the face that looks a little bit sagged and a little bit droopy. Next problem, and this is quite it's not so frequent. It's also not a problem of the N-glycosylation pathway. It's called tumoral calcinosis. Again, fancy words. Sorry for all the difficult words in my presentation. And it's a problem of phosphate in our body. Normally, we take phosphate out of our food and resorb it through our bowels. The excess of phosphate will be then excreted through our kidneys. In GALNT3 CDG, we see that the bowel is absorbing too much phosphate out of the food and that the kidneys are not excreting enough phosphate within the urine. This excess of phosphate will then make crystals inside of the soft tissue. This can be skin, but also muscle, and also the spaces around the big joints. We see that there are crystals, little bones, that are going to form inside of these tissues. The good thing about this is that, if you can call it a good thing, is that we have a kind of symptomatic treatment for this kind of tumoral calcinosis, because we know that the deposits that are formed over here will become less pronounced and will form less when we treat the patients with tetracycline antibiotics. We talked about pigmentation before. Within CDG, we have two groups that show abnormalities in pigmentation. First, the salt and pepper syndrome is associated in most of the patients with severe epilepsy. And salt and pepper, you see why you have the gray pepper grains next to the white salt grains. Then we have in as well POFUT1 and POGLUT1 CDG, which are both CDGs that only affect the skin and no other organ, a strange distribution of the pigmented zones, and associated with that, streaks that don't contain pigment at all. Sorry for the maybe ugly pictures here. Here we are looking to Adams-Oliver syndrome. There is one CDG reported that presents in this way. Again, not a problem in N-glycosylation. It's EOGT CDG. And here there is a problem in embryonic development. In Adams-Oliver syndrome, we have a problem that the skin during embryonic development is not closing as it should be. And it will mainly manifest at those places where you need good skin closure. And one of these places is the vertex. It's the highest part of your head. You can feel it for yourself. And we see there that there is a little defect going on here, which is already bigger. And here a small defect where you see that there are no hairs growing. The second manifestation that we can see in this patient is that also during embryonic development, the blood vessels in the skin are not doing their work properly, so that the development of toes and fingers are a little bit aberrant. And it can go really from toes that grow together to toes without no nails or that look already less like toes, or even a foot that is only half present, but I didn't want to show you horror pictures today. The last topic where we see skin problems in CDG is hypohidrosis. And the colleague before already pointed to this problem. It's the inability to sweat. And inability to sweat, yeah, that's really a problem when it gets warm outside, because if it gets warm outside, we cannot get rid of our heat, so our body temperature will rise and we will get problems. Like I told before, with the muscles that break down, getting seizures, etc. It's not well described in CDG patients, but when we hear the stories of families, we sometimes hear, okay, when it's warm outside, my child always has a fever. And it's not always obvious if it's then really fever because there is an infection going on, or if it's fever because the child cannot get rid of the heat that it's producing. Sorry, that wasn't meant to be. The inability to sweat goes together in some CDG patients with other symptoms. In some patients, we see that they also have an insensitivity to pain, which is also something important to know, because if you're insensitive to pain, you will touch warm things and you will burn yourself without knowing. You will prick yourself, have an ugly wound that won't heal, that will infect, and it can give really bad symptoms. Some patients have immunodeficiency, so a lot of frequent infections starting from young age, but also going on later on. Something funny called palmoplantar hyperkeratosis, and this means that the upper layer of the skin, the epidermis, is much thicker than normally, so it is really a callus on top of the palms and the soles. And also teeth problems, and it can go from what they call enamel hypoplasia, so that the teeth are not well developed, to slighter problems. That means that the patient gets very early bad teeth, caries and little holes in the teeth. I hope that it was a little bit informative for you. I kept it pretty basic, so if there are questions, you can ask them after this session or even between sessions. At the last slide, I still want to thank all the people in the lab. I'm currently finishing my PhD, so I think that they earn a place of honor for all the work on CDG that has been performed in our lab the last few years.